We're going to move on to our next set of keynote presentations and fixing some other AV issues. Just let me know, and then we can go back to sharing. Yeah, we just have to stop screen sharing. All right. So it's really my pleasure to welcome three speakers for this next presentation that's focused on the development of and implementation of plans of safe care for substance-exposed newborns and their families. Our first speaker will be Dr. Deborah Monaghan. Dr. Monaghan is a family physician who's focused her career on population-level health outcomes, working for both CDPHE and currently for the Colorado Department of Human Services. In her current role, she provides process and policy oversight for the physical and behavioral health needs of children and youth served by Colorado's juvenile justice and child welfare systems, and supports families and caregivers partnering to assure their well-being. Lauren Bruns is an assistant professor of pediatrics with CU School of Medicine and works clinically as a newborn hospitalist at Denver Health. In her non-clinical time, she serves as a steering committee member for Chosen Quick and Support Colorado as Plans of Safe Care Work Group co-chair. She's also the PI of Denver Health's CMS-funded Maternal Opioid Misuse Grant, which supports the Perinatal Navigator and Peer Recovery Support Program. Then lastly, Shannon Bryan. Shannon Bryan is the Substance Use Disorder and Substance Exposed Newborn Specialist for Colorado's Office of Children, Youth, and Families Division of Child Welfare. Shannon has a master's in public health with a focus on family and child health, as well as 10 years of experience leading and facilitating multi-system projects to improve outcomes for children, youth, and families involved in the juvenile justice, child welfare, and mental behavioral health systems. So looking forward to this presentation. Now we do have Lauren, I believe, presenting virtually. So I see her face up there. Shout out to Lauren, who ran the Boston Marathon yesterday. From what I saw in the news, she did not win, but she did run it.
So close.
Thank you, Taylor. Oh, I love it. I can see Lauren on the screen here too, which makes me really happy. All right, holler if anything's not working technologically, but we're going to get through this. And before I even say hello, I have to say following Laurie is so fantastic in so many ways. I'm planning to submit a voluntary vitreous humor sample to you at the end of the day. So if anybody wants to join me, please just find me after this is over. But no, thank you for your energy. All the presentations have been fantastic. And I think that energy will get us through one more block before lunch break. So super happy to be with you all. Yes, Deborah Monaghan, she, her pronouns. And my role will be really just to tee up our work here. And I'm wondering where I'll be able to find our slides. I don't want to lose Lauren though. Would I just go to that one?
No, we're going to screen share pause and then she's going to share hers. So we're going to share our screen to start.
Oh, perfect.
And we may lose Lauren until she comes back on for her portion, if that's okay.
Okay. And I should be pretty quick. Thank you.
Yeah, that's the issue with the.
So, do you need notes?
Yeah, I think we all probably will need to be able to share the slides.
Then I think a lady could advance from the other end.
Okay. So I think there's just no way to do where we're not sending this in the game. It's going to be extended.
Laurie, do you have any like witty jokes you'd like to?
Okay.
Okay, I think we'll go with this for time, and then we'll make sure we get Lauren up there in just a moment. So we are going to talk about plans of safe care, recommendations. And I have just an overview slide to really kind of tee up what we'll be talking about in this session right before lunch. So as a bit of background, the Colorado Plan of Safe Care was updated in August of 2021 by the Plans of Safe Care Work Group, and that is a subgroup of the Support Colorado group. And we identified kind of three areas of further needs as a work group. One of those being just basically an explanation of what is a plan of safe care, the background of it, the scope of it, and then being able to articulate that to all type of collaborators, users, creators, et cetera. So everyone being on the same page about what a plan of safe care actually is and how that can be used. And then the other two buckets that we're going to talk about really are the bucket of healthcare-based providers, which Lauren Bruns will talk about, and then the Colorado Child Welfare staff, which Shannon will be speaking to as well. So for the healthcare providers, the few things we wanted to go through really was specifics regarding physiological readiness of an infant for discharge. We also want to talk about supporting discharge planning, including assessment of the family and caregiver, which we've talked a lot about today, their readiness, and then also the referral and resource considerations. I know back from the data slide, I think from you, Susan, that warm handoff is certainly an area of opportunity that we have as a state. And then also on the healthcare provider bucket, recommendations for collaboration within the healthcare setting. And then from the child welfare piece, you're going to hear from Shannon. We're going to kind of go through standardized implementation of our plan of safe care practice across counties. Colorado has 64 counties. From a child welfare standpoint, we're a state run, but a county administered child welfare state. So there is a lot of variability, as you can imagine, in 64 counties. So really trying to standardize that implementation and some continuous quality improvement within that as well. Oh, thank you. And then also from the child welfare standpoint, enhancing our cross-system education and relationships between child welfare, healthcare professionals, and the judicial system. All those pieces, as you can imagine, come into play in this realm as well. And then lastly, from the child welfare standpoint, assess the impact of plans of safe care implementation and practice on child welfare involvement and outcomes. And then lastly, the Plans of Safe Care work group has also created a best practice recommendation for plans of safe care. This work group worked with a lot of partners to put this together. It is a living document to be shared and distributed, which we're super excited to be able to do for hospital-based providers and really everyone involved in part of the planning of that plan of safe care and implementation through the whole perinatal period. And currently that's being reviewed by the Division of Child Welfare staff at CDHS, where I work, and county child welfare staff as well. Once that's approved, it will be distributed to all county child welfare agencies, along with different training opportunities, TA opportunities, and material resources. So with that, I am going to hand it over to Lauren Bruns, who definitely has a good reason for joining us virtually, and hello from Boston. So at this point, I'm not sure the best way to. I was planning to advance them for her, but
okay.
That's perfect. Yeah. Can y'all hear me okay?
that's certainly fantastic.
Let's see. Oh, maybe here. Meeting controls.
Go. So we put her up there, then
Will not be heartbroken if folks cannot see my face.
We might be heartbroken, Lauren, even though I know you won't be. We know we can hear her.
Yeah. Yeah, but I don't think. Yeah. All right. Well, it is what it is.
I will take this time though to thank Susan and everyone else for telling me to cancel my flight to fly back after the marathon last night to do this presentation in person. So props to you guys for having my mental health and work balance life in check.
All right, Lauren, we're gonna have to do this without actually seeing your face on the
That's
screen.
perfect.
And
Totally
we're gonna
fine.
ask you to increase the volume on your mic or for you to shout into your computer so we can hear you, okay?
Okay, perfect. Is this enough shouting?
A little more shouting.
More shouting. Okay. So I will go through this fairly quickly because I really want to be mindful of giving Shannon some time, because I think that her presentation is going to be really important, and I want to make sure folks have the opportunity to ask her questions. And so really briefly, just kind of giving an overview of what these best practice recommendations are for our healthcare-based providers. So we really wanted to give specific recommendations on how folks working in a healthcare setting can prepare for the safe discharge of infants based on plans of safe care. But I want to be mindful of the fact that these recommendations do not address kind of specific recommendations for the medical care, pharmacotherapy management, feeding nutrition for infants, and really kind of allows hospitals to make those medical decisions based on their own institution-based policies. What these do address, though, are kind of specific guidelines to have in mind that are focused around Eat, Sleep, Console, which is, I think, kind of becoming the standard of care thanks to the Chosen Quick efforts for most of our state hospitals caring for infants with neonatal opioid withdrawal syndrome. And we do make specific recommendations for discharge coordination and planning. And so if Deborah, if you want to advance to the next slide, these recommendations are going to be distributed to healthcare based providers. And so I'm not going to go over these specifically. I just wanted you guys to be able to see what these are going to look like so that you recognize them when these do go live. My screen is not advancing, so I will assume, Deborah, if it's okay, that we have advanced through slide 93, 94, and 95, and perhaps we are now on slide 96. Is that an accurate guess?
It is now. Thank you.
Okay, excellent. Love that for us. So as you guys can see, those are what these recommendations are going to look like in that live document that will be shared with y'all. But I do not want to spend any time kind of going over those specifics. What I do want us to take a peek at, though, are kind of the overview of what these things address. So in terms of the physiologic readiness key points that this document will address, we're going to go specifically into what things healthcare providers should be looking for to determine if an infant is physiologically ready to discharge based on their Eat, Sleep, and Console scores. And then also making sure that healthcare-based providers are being mindful of addressing diaper dermatitis prior to deciding that this infant is physiologically ready to discharge. And again, to reiterate, these best practice recommendations do not give specific management recommendations. Those should be kind of deferred on a hospital policy level. But just as a reminder to healthcare-based providers to be mindful of these things when they're determining if an infant is physiologically ready to discharge. And then finally, going into essentially the resource inventory and referral recommendations, which I think I like to kind of put in a bucket of coordinating safe discharge on a multidisciplinary level. And so this certainly needs to happen in collaboration with DHS when that is appropriate. And I think of that part kind of in terms of three subheadings. So what are infant-specific medical-based referrals that are appropriate? What kind of home visiting programs, family support programs, public health nursing services, things like that are appropriate for this family? And then again, as the core foundation of plans of safe care, making sure that we are addressing the parental mental health and substance use disorder support and treatment. And so in the next slide, these supportive discharge planning specifics are kind of broken down into basics that healthcare providers should have in mind when they are working in a multidisciplinary team to prepare for the safe discharge of infant. And so I think one of the things that is incredibly important is to make sure that we're involving all caretakers, and that is in the instance that infants are being discharged with non-birthing parents or non-biologic parents. as well as infants who are being discharged with their birthing parents. And so again, I think the thing to be mindful of is that the goal, just like Dan was saying, the goal at the end of the day is to move towards family reunification. And so even if an infant with NOWS is being discharged outside to caregivers outside of that home, those biologic and birthing parents need to be present for these decisions, because ultimately the goal is to get that child back with that family whenever is deemed safe. And so making sure that that all of those folks are at the table when these discussions are happening, and then also making sure that we are involving all of our health hospital-based care providers when we are prepping for discharge. And so oftentimes our healthcare techs, our bedside nurses, our social workers are really the ones on the front lines of caring for these families. And so making sure that we're asking these folks how these interactions with families are going, and eliciting feedback from where there may be educational gaps that we can make sure we're addressing with families. And I think that kind of transitions nicely into just the emphasis on how important education is when we are prepping these plans of safe care. And so families truly need to be educated on safe sleep, sober caregiving, safe substance storage, secondhand smoke, kind of all of the S's, and making sure that those educational materials and kind of emphasis of that is provided throughout the birth hospitalization. And then also something that I have seen in practice is educating these families around referrals and resources that they are being provided for. So I've had some families offer feedback that when an early intervention referral has been made and early intervention contacts these families, they don't know what early intervention is. And so to have someone contact them and ask to do an in-home assessment can be triggering. And so making sure we're educating families on what resources we are providing after we are doing a resource inventory of what referrals and resources these families need. And then finally, communication it cannot be emphasized enough, and that is communication within our hospital-based teams, communication with our outpatient colleagues, and also communication with DHS when those folks are involved in the care of our families. I think specifically, and Susan, I think kind of got to this in the opening remarks in terms of how great we are in terms of providing education and communication with families in the perinatal period, and then doing warm handoffs after birth hospitalization. These are hugely important to make sure that we are communicating to our outpatient colleagues on what is the feeding plan for these babies, what labs need to be followed up, what referrals were made in inpatient, so that those folks can continue to follow up on that. And I think one thing that I have seen come up in my practice is when there have been concerns for infants feeding or not gaining weight appropriately after discharge, and the first thought is, oh, well, this must be a neglect thing, or this must be that these caregivers cannot feed this infant. When in reality, the feeding plan for fortified calories was not appropriately communicated to the outpatient provider. And so rather than the issue being that this was a caregiver who could not appropriately meet the needs of this infant, it was that infant was not getting the appropriate feeds because that was never communicated. So I think that there are huge opportunities in our communication with our outpatient colleagues to just take better care of our families and get them towards where they can really truly support their infants. And so we put all of those things together, and then moving into this last slide before I hand things over to Shannon, we kind of condensed our best practice recommendations into a flow sheet that we hope that hospital-based providers can just post in their workrooms, in their doc boxes, wherever they may be, as just a general overview of, in thinking of discharge preparation of an infant with in utero substance exposure, what are kind of the pillars that need to be addressed in creating these plans of safe care. And so what you folks can look forward to see being distributed are these flow sheets that you guys hopefully will hang in workrooms and doc boxes and use as a quick reference in what to remember to address in preparing our infants for safe discharge. And then as Deborah had shown in a few earlier slides, that Word document, that is going to be that much more lengthy kind of descriptive document in our best practice recommendations. So I know that was a whirlwind, but I want to make sure that I give Shannon enough time, because I think what she has to say is going to be really valuable, and it's sort of kind of a black box, I think, especially to healthcare providers. So I will kick it over to Shannon.
Awesome. Thanks, Lauren. Can everyone hear me? Just checking. Closer. Okay. I will also shout into the mic, even though I'm right here. So Lauren, I hope your race went well. Can't wait to hear all the details. Everyone, thank you so much for having me. My name's Shannon, she, her pronouns. And I'm here to talk a little bit about that black box. So when healthcare providers and child welfare come together, like, what does that look like? Why are you getting asked the questions you're getting asked? And like, what are those next steps? I will also say that in that best practice guide that's being linked to, the like nitty gritty details of child welfare practice is also in there, because there's the best practice guidelines for healthcare providers, and then under that are also the best practice guidelines for child welfare that we're making sure is getting ready to be trained to kind of across the state. So if you're someone who really loves getting weedy, you can go ahead and dive into that, and that'll give you kind of a more full picture of what I'm going to talk about. But I want to start by kind of centering us back on what Callan brought up, which was that statute change around the substance use disorder recovery, and that key definition change. What happened was there was that removal of reference to the federal schedule, the federal drug schedule guidelines, and there was also the removal of reference to the toxicology results, which was really important. One, yes, because of what you all do around mandated reporting. So, right, like substance exposure of a newborn does not mean that you have to automatically call child welfare. It also changed how we in child welfare review and respond to those calls that you're making. So there's the definition again. It's affected by and threatened by. If you walk away with two kind of phrases related to child welfare, I really want that to be drilled into your mind, is that any case in which a child is born affected by alcohol or substance exposure, and you can read the rest, and is also threatened by that substance use. So those are the two words that are really important to kind of drill down on. And I'll go to the next slide. And I wanted to put this up here because affected by and threatened by isn't just some willy-nilly term that folks can kind of define for themselves. This is very clearly defined in Colorado law. So just wanted to go ahead and let you know that when we're saying affected by alcohol, we're saying a child is born affected by alcohol or substance exposure when it impacts their physical, developmental, and or behavioral response. I'm going to stop here just to say our child welfare professionals are not medical professionals. So this is really where your information, your expertise is super valuable. And we'll get into that in a little bit. Threatened by. The newborn child's health or welfare is threatened by substance use when the medical, physical, and or developmental needs of the newborn is likely to be inadequately met or unable to be met by parents and or a caregiver. So as was referenced, right, a kiddo could have been exposed, an infant could have been exposed to a substance in utero, but that doesn't mean that they're currently threatened by that substance use. There are a million reasons why they could have been exposed to previously, but not threatened by right now. So I think we had a couple of those examples shared earlier. While you're doing this, while you're meeting with families, it's really engaging them and having these conversations, because we'll be doing that as well as child welfare professionals. But if in that referral, we say, oh, there is no threatened by, we're not getting involved. So, and we'll go into that again a little further, but I just wanted to really highlight, we're not making these terms up. We are very clearly guided by the law. All right. So I've been having a lot of conversations with different medical providers, and they're like, well, when we call hotline, like, why are we getting asked about toxicology results? We thought there's not an emphasis put on this anymore. Why are they asking us the questions that they're asking us? And I just wanted to share with you that there are 5 key questions that when you call the hotline, all hotline staff are asked to ask if substance exposed newborn is identified. And you don't have, like, they're asking this because they're trying to get all the information necessary to determine their level of involvement. If you haven't done a toxicology result or toxicology test, that's fine. They just need to ask it because they're trying to get all the information possible, because we don't want to get involved unless we need to. So why not ask you all before we, come in and disrupt a really kind of delicate and precious time between a birthing individual and their infant. So I'm going to share the 5 questions with you just so you really know what's happening. And this is verbatim from like what the hotline staff are seeing. So was the infant born substance exposed? If yes to that question, select all that apply. So they will ask, has the infant been substance exposed? And then they'll say, well, how do you know that? Right? Like, are you just guessing? How do you know that? And it's okay. They'll say, is it because of a drug screen? If it's not, then they'll just want to know that information of like, okay, well, how do you know this? And in your professional opinion, that is great. You relying on what you're seeing tangibly in the moment, that works. We don't need to have a toxicology test, but they're going to ask it because, again, more information is helpful in determining how involved folks are going to get. So if a drug screen for a child, then they ask what type of drug screen was used. The second, third, fourth, fifth question. So second, is the infant experiencing withdrawal symptoms? Again, they are not healthcare professionals. They're just trying to get this information from you. Was a plan of safe care or safe discharge plan created? If it has, ask the provider for this. So this is, again, where if you all are creating this plan ahead of time with your families, this is an opportunity for you all to save time when you're calling child welfare, because I know time is precious. But 2, so much of a plan of safe care is related to the care and well-being of the infant's medical, physical, developmental needs and the treatment needs of the caregiver as well. So things that child welfare, we rely on professionals for. 4, was the infant born with physical impairment associated with substance exposure? Were resources, referrals, or services offered? So these are questions you all, if you're doing a plan of safe care, or even if you're not, if you're just talking with your families, hopefully you're having these questions anyway. We're asking for detail to help guide our response. So what happens after a referral is made to child welfare? This is a great, I don't know how big or blurry it is for you all. It's available online. Great little rundown of what the child welfare process looks like after you make a call to the hotline or to wherever you're making that referral. Basically, the call comes in, a team of caseworkers talks about it. What's the information that we just received? So in addition to some additional questions, they're looking at the answers to those 5 questions I just showed you. So what was the information received? Is it credible? Do we think that there's a current threat, an impending danger to a child right now? Has child abuse or neglect happened? After reviewing that information, it kind of goes 2 ways. You can see that on there. I think we're going to focus more on that yellow side. So child welfare caseworker conducts further assessment. What does that mean? Like, how long does that take? Okay, I called hotline and I've talked to professionals, be like, well, why do people come within 2 hours versus 3 days versus 8 days? Like, what is the difference? Why? So what's the response time? And honestly, it really depends. Not all families are the same. So our response time is not the same. And our response time is dictated by what was put in that referral, by what we reviewed from that initial call, which again is why having that detail and information is really helpful and necessary for us to say, all right, we need to be there like this, like in 2 hours, this family's discharged, there are some serious concerns coming up, or hey, maybe there's some concerns, but it seems like the safety is really being addressed right now and we can get there in 3 days. And so there's some of this conversation that's had. And again, we don't make up the timelines. I'm not going to pull out our whole manual, but it's an in-depth process of training. It's all in statute and law. So we're not making this up when we're saying, okay, we're going to do 8 hours, 3 days, whatever. We have very clear guidelines that we have to go through when determining response time. If you're interested, that's a little detail to where you can check it out, but okay. So what happens after a referral is made to child welfare and it is determined that further assessment is needed? So that yellow box, like, all right, they're going to come. What happens next? And why are they asking all these questions of me again? So intake caseworkers will do an assessment process. Included in that, if a plan of safe care hasn't been completed, is completing a plan of safe care with the caregiver, the birthing individual, family, medical team, trying to figure that out. But then also completing the safety assessments that, again, we are required to complete by law. And then we, based on the information gathered through that process, we determine what the next steps are and how involved or not involved child welfare may be. I'm going to take a second just to say that I've had some conversations recently too of like, okay, well, like, why do you get involved or not involved? And like, if like, why is a caseworker not removing a kid? Or why are they removing a kid? And again, this is very, very detailed. And I think you can look at some of that in the law if you'd like to, but just as a high level understanding, there's kind of a few different pieces to this. So response time dictated by what we get in the referral. How we respond and how we become involved is then going to be determined based off those safety assessments. And what we're doing there is saying, is there current or impending danger to the child or youth? So current or impending, not like, well, in like a month, we're kind of worried about this thing that might happen. No, like current or impending danger will determine if we really need to get involved today, right now, this moment. And there's gray areas of gray, right? Like there's not, we're either getting involved in removing a kid or we're not getting involved. There's a whole spectrum. And I will just say that the decision to remove a child from the custody of a birthing individual is a huge decision. It's not one that child welfare workers take lightly. It's not really one that we want to make, and it's not one that we do make. We do have these assessments. We have recommendations. Child welfare individuals cannot remove a child without the court ordering it. So that's another piece, just to kind of layer into the complexity of moving pieces. Probably also another piece of our education more broadly around plans of safe care and what this change in law actually means. But human or social service custody child welfare will only take custody if we believe two things. One, there is current or impending danger that is threatening like the life of this child. And two, there is not adequate support to control for those dangers by keeping the kiddo in the home. So either the caregiver doesn't have the resources or the supports, the family unit that is around this infant doesn't have the supports. So it's twofold because, right, there's risk inherent in life. All families at some point encounter danger, risks, threats to safety. It's more how severe is it and how much can the family control for that threat? And that's also where plans of safe care, right? Really helpful to know what are the referrals being put in place? Are there more than one caregiver in the home? Like what is kind of this nucleus around the family that's supporting them? And if there's not one, then that's maybe where we're going to have to talk about how involved we become. So again, there's a lot more that I could dive into this specific area. There's a lot of nuances. And there are very clear guidelines that we follow and a checklist that we have to go down, including involving the court before child welfare will ever remove a child. So just wanted to, that's as a small bullet, but also a big bullet. So child welfare response involvement, I'm going back to kind of, okay, so child welfare is going to get involved. They're talking about plans of safe care. And I just want to highlight here how important healthcare provider input is to this entire process. So if a caseworker comes out to a healthcare facility because substance exposed newborns have been identified, then they, in addition to asking if a plan of safe care has been developed, there are mandatory questions they again need to ask. The first 5 are related to the same things that were on hotline. It's redundant. It's also important kind of to be redundant, to really make sure that things were accurately captured in this moment. And this is really where we start engaging with the families as well as the providers. So these are the questions, again, verbatim, that they are asked to ask. Is there a plan of safe care or a safe discharge plan? Has the infant or caregiver received resources, referrals, or services? Here, in hotline, they may or may not have asked you to identify them. Here, they're really trying to gather that information to determine level of involvement going forward. Is the infant experiencing withdrawal symptoms? If yes, they're asked to describe the support plan specific to the symptoms of withdrawal. Again, child welfare workers, not healthcare providers, not the expert, really asking you guys, all right, so this kiddo, they're experiencing withdrawal symptoms. What do they need to be safe? What do they need for their well-being and to thrive? Like, what's the plan going forward? Next, kind of those questions around eat, sleep, console. And then also your observations as a team that has been with this family, like, and here some of caseworker observations also come into play, but like, do the parents and caregivers display competency in taking care of their infant? Can parents or caregivers assume full responsibility for the infants? And have 2 caregivers been identified to help support the care and taking of the infant? This is important. I think it was brought up in the other presentation as well, that, you know, taking care of a baby who's substance exposed can be really hard. And there's a lot of complex needs that an infant will likely have, in addition to the caregiver's needs, the birthing individual's needs. Do they have the support to take care of their own needs and their baby's needs? And if the answer is yes, that is great. If not, we're going to just kind of ask, okay, well, what's the support plan? How can we support the caregiver in meeting those needs of the substance exposed newborn? Has that been talked about? So again, these are verbatim what they're going to be asking and getting information on. And all of this really requires and is so much more comprehensive with the input of healthcare providers. So I shared basically, you know, what that initial piece is, and then I just want to highlight opportunities for collaboration. One, work with your teams to understand your own hospital policies regarding reporting substance exposed newborns to child welfare. The reason I say this is because right now it's all different. Just like counties are different, hospital systems are different. And so I think it's really important for you all to understand what your own policies are, and then also share that, right, with the child welfare agencies that you do have contact with and are working with, because they don't know what your policies are. Your hospital may say, we will call on every substance exposed newborn no matter what. And hotline will be like, well, why are you calling us? There's no current impending threat, danger. But it's important, right, for our collaboration to better understand what each of us are required to do. Work with your teams to develop processes for completing plans of safe care at the earliest opportunity possible. Again, right, because we in child welfare will ask that information. It is so crucial for us to determine how involved, if we get involved, how involved we will get. So if you've already started developing that plan of safe care, not only are you supporting the birthing individual and that family unit and that baby, but you're also helping to support our team if we do need to get involved in our ability to meet the needs of the family as well. When calling child welfare to report abuse or neglect, provide as much specific and observable information as possible. Again, because we respond based on that call. We don't respond on, conjecture. We really need to see what's in that report. When talking with a caseworker and completing an assessment, I just said that. Oh, but I will say that when I'm saying provide specific and observable information, the more specific you can be, the more helpful it is down the road. So saying, well, we don't think caregiver can meet the needs of this baby. Well, why? Right? From your medical point of view, why? That's what our caseworkers need to know, because again, not medical professionals, hard to interpret all of the information that you have around symptoms and how mom and baby are doing. And then talk with your teams also about creating learning opportunities with your county child welfare departments. Larimer has done a really great job of doing this. I was able to observe one, I think last week, 2 weeks ago. Yeah. So really helpful, really beneficial, because again, right, hospitals, different medical providers, they all have their different policies. Yes, we're having best practice guidelines. Yes, we're trying to have the toxicology guidelines, but you all work differently. You expect different things. And child welfare, right? Like, we need to better understand who your teams are, how we can work together. If you're like, no, this is really urgent, how much easier would it be to get a response if you also had a relationship with the team, right? So I would just say, and that goes both ways. I think this is really high level. What does child welfare do in this moment? And there are so many nuances. So the more that you can get to know our child welfare teams in the counties that you work with, and the more they can get to know your teams, the more we can support our birthing families and those infants in achieving better outcomes, and hopefully not removing them. Contrary to a lot of popular opinion, we don't want to take babies away from their mom, from their families, from their caregivers. We really want to try and support them in the home as much as possible. So the more that we as systems can integrate and communicate and collaborate, the better we can do that for our shared clients. So that's what I got.
There we go. I'm Kelly Bernardo. I work up at Poudre Valley Hospital up in Fort Collins, and I got the opportunity to meet you a week or two ago, whenever it was. So thank you. It's great to see you again. Quick question in relation to the plan of safe care. We do a lot of work with that very collaboratively with DHS, especially in Larimer County. However, I feel like that's not necessarily something that's initiated prior to the phone call that's made to DHS. I feel like yes, I mean, we're starting to do that teaching. We're doing those prenatal consults ahead of time whenever we have that ability to do so, which is great. And we start those conversations. However, I do feel it's critically important the quicker you guys can get involved when it's necessary for you guys to be involved, because I feel like the guidance that we need from you and your team helps us to also navigate what direction the care of baby needs to go. And I feel like sometimes, depending on placement of baby, whether that's going to remain with parents, which we hope is always the plan, or kinship placement or whatever, that a lot of times that can dictate who the PCP follow-up is going to be. And that can then dictate what potential resources we may be steering this baby toward for follow-up, or for, whether it's a different county for EI referral, or, we have the luxury of having a lot of really great community programs available up in Larimer County, but they're associated with specific, who your PCP provider is going to be. So, and knowing, can we make a referral to our Healthy Harbors program, our Medicaid Accountable Care Collaborative? What does that look like? So I feel like when this is asking for the plan of safe care or a copy of that to be provided, I guess, is there a template that exists for that? That's something that we can have to start kind of checking boxes to when we're in that initial process of either having those prenatal meetings or, making those referrals to you?
Yeah.
To help us move that process along, even as we're continuing that collaboration.
Yeah. So I think, on the child welfare side, no, we do not have a specific template for you. However, I'll say two things. I think, one, there are, and I don't remember the name, but maybe Jade can yell it out to me. There are some hospital systems who have developed templates and have it in Epic, and I believe they would most likely, I would assume they'd be happy to share it, but I cannot speak on their behalf.
Lauren Bruns, are you there?
I'm here. I
Did
was just
she-
going to say, yes.
Yay! Okay.
Am I still lying or am I yelling enough? Yeah, so I basically took the Colorado plan of safe care that our work group amended last summer and embedded that into Epic, our electronic medical record. And I'm more than happy to share that with folks.
Man, I was trying
All
to
the
get
more
you on
reason for your
screen.
hospital to join Chosen Quick, because that is one of the tools that we have as part of our intervention toolkit. Other questions?
Oh, I will just say one more. In addition, right? Like all of that takes time. So I think if you can think about those 5 questions that hotline are going to ask, but then also think about, okay, well, and this is also key to some questions around toxicology results. I know folks are like, even if we do a toxicology test, often it is sent out and not available. Exactly. And that's okay. That is where it's really, okay, well, what are you seeing? Let's be specific about what you're seeing and what your concerns are. Let's talk about how that is a threat or danger to this infant right now. And let's talk about what you're seeing related to the caregiver or the family's ability to meet the needs of this infant. So I think really thinking about those basic things, if a plan of safe care isn't ready, is really important. And then when a family or when a intake worker does show up, then thinking like, okay, well, maybe I don't have all of the specific referrals ready, but I still know what this infant's going to need to address their withdrawal symptoms. I still know generally what the substance use treatment or physical health treatment of the birthing individual is. So I think if you can share that information more broadly, that's great. I think, right, also a plan of safe care is meant to go home also with the caregiver, both with the birthing individual or whoever is taking the care of the infant. And these things change, right? Like the health and well-being of a baby, of a birthing individual, even honestly, the family or the foster family that gets involved, those things can change daily, hourly, because of some of these complex medical issues that we're seeing, but also just because of life. So recognizing too that we don't have to have all the answers. We don't have to get it perfect right away, but the more information we have based on what you're seeing right now, and the more specific you can be, the more we can then gauge our level of involvement, and it can always change. So that's just the other piece I would add.
Last question.
My name is Ben. I'm a primary care doctor in Fort Collins. I met you I saw you at the event a couple of weeks ago. My question is kind of a translational one. I'm struck hearing all this enthusiasm and all this wonderful direction and intention with the challenge of having this become a part of the informal environments that we're all working in. I'm thinking about the call rooms and the nursing units and the around the water cooler related to the conversations that we're having interdisciplinary in an interdisciplinary team in our hospitals. And I'm wondering if you could speak to the discrepancy between the timing of this affected by, threatened by framework since June of 2020 has been there, it seems like, and yet it's certainly not what we see in our institution. It sounds like it's not always the way. It's not the guiding principle in the interactions with welfare services across the state. I think it's not universally the case in Larimer County. And so I'm curious if you could talk a little bit about what the conversations are like within CDPHE and broader groups about how we're still where we are at this time and how we can, as we reintegrate into our environments after we leave today, how we can accelerate that change.
Yeah, I might have Lauren go first and talk about maybe from that medical environment, and then I can jump in with kind of how we're looking at process within child welfare, but also the collaboration piece. I couldn't figure out.
Yeah, Ben, I think that's a great question. And honestly, that is something that I struggle with in my clinical practice. And I would consider myself more embedded into this kind of clinical context than most providers. And I would say that my experience has come from the knowledge base that I have had in working. I was part of the rule writing group with child welfare, and honestly, the areas in which I have found to kind of initiate change have truly been in like the personal interactions with my colleagues and with our hospital-based social workers, in terms of when we, as the medical providers and working with our medical-based social workers, are the mandatory reporters. And I think the only reason that I have had any kind of success in translating that change that has been has been written since June 2020 into actual practice has truly been like word of mouth interfacing with colleagues and with my medical-based social workers. And I think that is a huge area that we need to improve and just kind of work on the translation from, yes, this is what is written in law now, to that trickling down to a hospital-based policy level. And I think that that is a huge barrier. And I truly do think that like where that change is going to happen is, like you were saying, around the water coolers with providers who have this knowledge base of what the new definition is and how that impacts the care of our families, doing that at a hospital-based level. And so I think, for lack of better institutional change at this point, it has come from individual efforts at the hospital-based level, advocating for what we have to do to take better care of our families in accordance with this new definition. But it's hard. I'm going to be honest. Like it's really tough, and we need to do better.
And I would just add, from the child welfare perspective, and just in general, right? Like this law came out and we're still playing catch up. It's hard. So I'll say the same kind of frustration and the slowness that maybe folks are experiencing within the medical profession. We're also experiencing across Colorado and in child welfare. I think some counties are further ahead than others. And right, like, sorry, blank, but I would just say, like, all counties are kind of approaching this a little bit differently. And when we implemented the law, then COVID happened and it shut down. And so the ability to kind of train to and grow these relationships and this collaboration wasn't really there until this, it's been happening, right? Like, so we're a part of these larger state conversations. That trickle down effect, though, has really been slow to happen, especially in our agencies. And in our introduction, we were talking about a few things that child welfare itself is trying to do. One is ensuring that best practice guideline is very reflective of what child welfare practice is, but then also creating those tools and those training opportunities so that our caseworkers know what the law is, know what the expectations are, know how to incorporate that into their conversations and their practice, but then also so that they start to have an understanding of what you all are experiencing. So I think our caseworkers and our healthcare providers have some of the most stressful jobs, I think, when it comes to like working with these kiddos. And there are so many moving pieces and there's so much going on. And I think a key piece is really having these conversations at that county and community level so that our teams can understand each other. We can know what's happening. And a couple different things. One, I'm available to help kind of moderate and facilitate conversations. Sometimes this is needed. But then two, if folks are interested in, pulling together some more trainings, but maybe don't have capacity because of just whatever is going on in their county or region, like that's something that the state, and I know Illuminate is also really interested in supporting. It's a long, slow process. It's something that we're trying to get more consistent within child welfare. We're doing trainings around that, providing more education. I actually took a note during the last one. I was like, we need more toxicology presentations and information for our caseworkers. And then I'll just add the other piece that's really important is it's not just our two systems, it's also the judicial system. And that's the next thing that we need to tackle because again, sometimes the judge is the one that wants the toxicology result. It's not actually the caseworker. And so how are we having those conversations with all the systems that are coming into play and like starting to impact and affect these families? So it's not concrete answer, but that's what's going on.
And I'll just make a global comment. We're in the midst of a paradigm shift. So we started trying to change that language in 2012. It took us 8 years to change the language in law. It's going to take us at least that long to figure out how to implement it across our state. A plan of safe care is for every infant that's prenatally exposed. Child welfare is for infants at imminent risk of moderate to severe harm that can't be controlled by other factors. It's going to take us a long time to figure that out. We need our healthcare providers joining us in making sure that we're reporting the families that or making referrals to child welfare for the families where that truly is the case. This infant is not safe to go home. Other than that, we have to partner to wrap around families to give them everything they need to take their baby home safely. I also just wanted to say through Support Colorado, we have a plan of safe care work group where you've been hearing from. We have a provider education work group. We have a policy analysis work group. We also need providers like you to help us get this language out to your peers and your partners the way that Lauren was sharing. So join us, join Lori. She's got her hands up. I'll pass it off to her. But there's lots of opportunity to engage.
Thanks, Jade. Super fast. Jade mentioned this, but I'm the co-chair of our provider education work group under Support Colorado. And what Shannon was just talking about, trying to get these two systems to talk and really to talk on an individual level, like Lauren was saying, like around the water cooler, that's the holy grail, right? And we're trying to make that happen, but we need literally like human beings, individuals who care about this to make it happen. So if you are one of those human beings who cares, please find me. I will give you my cell phone number, text me. I'm always awake. And we'll hang out.
So I think what we're getting at here is there's lots of great policies and guidelines that are coming through the pipeline, but how do we really operationalize it? You can make up all this stuff based on the literature, best practices, but how does that really look at the bedside, in the hospitals, and all the places where we work? And we're actually going to spend a chunk of the afternoon focused on that. We're doing lots of transitions work, great suggestions coming out, but the key piece is exactly as what you just highlighted. There's a gap between what we know as best practices and then what is actually happening at the bedside. So how do we bring the two together? So with that, let's break for lunch. If y'all have about half an hour, you have to return at 1 o'clock. In the meantime, I am going to put a slide up there. For those of you that are hospital-based, there's going to be a QR code that pops up, and we're trying to get some site-specific data on what SEND-related work you all may or may not be doing. So please scan that code and fill that survey out during your break.